So we'll start with valvular disorders. First of all, the most important thing, as you can see in this image, is localizing where the murmur of which valve would be heard. So this is a really good diagram here, and I'm gonna give you a really good mnemonic for that as well, so it's gonna make really easy for you. So it starts on the right, then goes on the left side. It starts on the second intercostal space. This is second, this is fourth, and this is fifth. Second, fourth, fifth. Second, fourth, fifth. So how you're gonna name these areas is really important, and that is what's gonna make all the difference. So this one right here where my cursor is pointing, that's A. The second one is P, this is T, and this is M. So if you remember the mnemonic A, P, T, and M, so that is gonna make A, P, T, and M. So A and P are at the second intercostal space, T is at the fourth, and M is at the fifth. M is at the mid axillary line, and these are just adjacent to the sternum. So A represents aortic stenosis, P represents pulmonic stenosis, and T represents all the tricuspid issues, and M all the mitral issues. So let's just give another overview. The central location between the P and T, where this line is, where I just highlighted with red, this is what I call A and P regurg line. So this is A, this is P, this is A and P regurg, this is T, and this is M. So when we come at it again, it's gonna be A, P, A and P regurg, T and M. And just one more thing, the ASD and VSD, how are you gonna point towards ASD and VSD? So that is also really simple. ASD, ASD, VSD. The one at the top, that's just ASD, and the one at the bottom, that is T, is gonna be ASD and VSD both. So you've covered all the murmurs with just two mnemonics, and you can combine them into one as well, and that would be A, P, A and P regurg, T, M. ASD, ASD, VSD. So it's just a complete sentence which goes like A, P, A and P regurg, T, M, ASD, ASD, VSD. So if you can just visualize this line in your mind, it's gonna make it really easy for you. So the line goes like A, P, A and P regurg, T, M, ASD, ASD, VSD. So just keep this line in mind, and that covers everything. Other than that, it's really easy. It's gonna be the A area is for aortic stenosis, the P area is for pulmonic stenosis, the A and P regurg, that already represents that it's aortic and pulmonic regurg sound between the P and T, and the T is for tricuspid stenosis, tricuspid regurg. M is for mitral regurg, mitral stenosis, mitral prolapse, everything associated with the mitral valve. And as I told you, ASD, ASD, VSD. So ASD would be heard at pulmonic area as well as the tricuspid area, whereas the VSD would just be heard at the tricuspid area. So we'll give that line another go. A, P, A and P regurg, T, M, ASD, ASD, VSD. So just remember this line, and it's gonna make everything easy for you. Other than that, it's just the specific areas. Why did I mention all these small nuances when I explaining this was because usually the aortic and pulmonic regurg are said to be at the third, or sometimes they might even mention at the fourth intercostal space on the left side of the sternum. So the people are like, oh, I think that was the aortic area. The regurg might be present at the aortic area, but that's not true. Regurg would be heard on the left side. Same goes for the pulmonic regurg as well. So if you don't remember exactly where the regurg is gonna be heard, it can get confusing, because the A and P area in the mnemonic, you might confuse that the regurg should also be heard at these areas, whereas this is just for A and P stenosis. Regurg is below at this area. And other than that, there's one more difference that I would also like to highlight is the sound of aortic stenosis depending on the etiology. If the reason for aortic stenosis is the valve, it's gonna be heard at the aortic area. If it's subaortic stenosis, it's gonna be heard above it at this area. And if the reason is hypertrophic cardiomyopathy, it's not gonna be heard at the A area because it's not a valvular disease, and since the obstruction is even lower at the level of the interventricular septum, it's gonna be heard at the A and P regurg area. So you need to know where the sounds of aortic stenosis might be heard. If the valve is the reason, it's gonna be A area. If it's supra-aortic stenosis, it's gonna go above at the first intercostal space. And if it's the hypertrophic obstructive cardiomyopathy, it's gonna go to the ANP regurg area. So A, P, ANP regurg, T, M, AST, AST, VST. So we're done with all the murmurs and all the associated locations of those murmurs, and now we're good to go. We'll give it a read as well. So, one more thing that's really important is you understanding what increased or decreased preload or afterload does to the sound of the murmur. The only important exception here is I've written it down here as well. Tip: the only murmurs that are an exception are the murmurs of hypertrophic obstructive cardiomyopathy and mitral valve prolapse. They get softer with increase in blood in the left ventricular chamber. All other murmurs get louder when there is greater blood in the chamber, as greater blood means greater flow across the valve, but they are the exception. So obviously, if the blood flow across the valve is greater, the sound of the murmur is gonna be greater in theory, but that is only true when it comes to all the murmurs, and that is not true when it comes to HCM and mitral valve prolapse murmurs. They get softer when there is greater amount of blood in the LV chamber. So let's discuss Valsalva. What happens to the preload in Valsalva? Most of the people get really confused, so I've also written it down here that what happens during the Valsalva strain phase. What you actually do is you try to forcefully exhale, closing your nose. And what that does is that increases the intra-abdominal pressure, compresses the vena cava, and that results in a decreased amount of preload, as well as external compression of the heart also results in decreased preload as the filling is reduced. So Valsalva is going to reduce the preload standing. What happens when you stand? The blood pools to the lower extremities, so the preload is going to reduce as well. What happens during squatting? When you squat, first of all, there is compression of all the big veins in the legs that results in increase in preload. Second of all, what also happens is there is compression of all the arteries in the legs as well. So there is preload increase and there is afterload increase. Both of these phenomena occur. But what is the predominant one? The increase in preload. That is the one that is more dominant. The venous run dramatically increases and the afterload also increases, but what you mainly need to keep in mind is the increase in the venous return, hand grip. What happens during a hand grip? The contraction of the muscles due to the hand grip result in compression of the arteries that results in increased afterload. You might ask, it's the same as squatting. Why is there no increase in preload that happens in squatting? Because both of them are basically muscular contractions. The reason is that the legs contain huge and big veins. That is why the contraction of the legs during squatting results in increased venous return, whereas the hand grip, the veins are not that much big and they don't contain a lot of blood. So hand grip is not gonna increase the preload dramatically, it's just gonna increase the afterload. So Valsalva, the preload is gonna increase, the blood in the chamber would also increase. So all the murmurs are gonna increase in intensity except for mitral valve prolapse and HCM that are gonna Valsalva results in a reduced venous return. So all the murmurs are gonna get softer except for the exception murmurs that were HCM and MVP. Standing results in reduced venous return, reduced preload. The amount of volume in the LV chambers is gonna reduce. That would result in all the murmurs getting, because the blood is less, all the murmurs are gonna get softer except for the exception murmurs that are HC and MVP. Squatting, It's going to increase the preload dramatically, and there is going to be more blood in the chambers. That would result in all the murmurs getting louder, except for the exception murmurs that were HCM and NVP. Hand grip, it's going to increase the afterload. So what happens when there is increase in the afterload? The transvalvular pressure gradient, like if this is a valve and there is greater amount of pressure due to increased systemic vascular resistance, when the blood is pumped through the valve, when the heart chamber contracts and pumps the blood across the valve, the flow of the blood is not gonna be that dramatic and that rapid due to greater back pressure from the increased systemic vascular resistance. So what is gonna happen in that case? All the murmurs except for HCM and AS, aortic stenosis, are gonna get louder. Why? Let's just discuss that one by aortic regurg. Since there is greater back pressure and the valve is not competent enough to keep the blood from regurgitating, the greater back pressure due to increased afterload is gonna result in greater backflow of the blood across the incompetent valve. So the murmur is gonna get louder. Mitral regurg, same goes for mitral regurg as well, because there is greater back pressure, there is going to be greater end diastolic, there's going to be greater end systolic volume left in the left ventricular chamber, and that would result in greater blood volume in the left ventricle, and that would result in greater backflow across the mitral valve. VSD, obviously, since the ventricular contraction won't be able to pump that much blood, since there's greater afterload, more blood would be left after the systole ends. That would result, and since the pathway across the systemic vascular resistance is offering greater resistance due to increased afterload, the blood is preferentially gonna flow across the ventricular defect into the right ventricular chamber, since more pressure is coming from here and less would be coming from here. So the blood is gonna flow across the ventricular septal defect. And same goes, since there's greater back pressure, the remaining blood volume after the systole would be great, so that would facilitate the outflow of the blood in diseases such as HCM and aortic stenosis. HCM, since there's greater blood and the interventricular septum would be thickened, the greater blood would open the outflow tract, resulting in softening of the murmur. Same goes for aortic stenosis. Why does the murmur of aortic stenosis get soft? This hand grip is really confusing, because this is one of those specific cases where both the AS and the HCM murmurs get soft. HCM murmurs, yeah, that makes sense, because the end systolic blood volume in the chamber of the ventricle would be greater, and since there is greater blood left in the left ventricular chamber, it would open up the obstruction. That makes sense. But why does the murmur of the AS also decrease? The reason behind that is because the blood is not flowing that quickly across the valve, the stenosed valve. Why is the blood not flowing quickly across the stenosed valve? Because there is greater back pressure. Yes, the blood is flowing through the stenosed aortic valve, but because of greater back pressure, the blood is flowing slowly, and since the blood is flowing slowly, that results in softening of the murmur. So the main key takeaway points were, you need to remember what happens during hand grip to HCM and AS murmurs, and other than that, the big tip that I just gave you was all the murmurs are gonna increase with greater blood volume in the chambers, except for the murmurs of HOCM and MVP. They are gonna get softer as there is greater amount of blood in the chambers. Other than that, the hand grip is a little bit confusing, so I'm pointing towards that again and again, that if they mention hand grip, which murmurs are gonna get softer? Obviously the HOCM murmur is gonna get softer, because after the systole more blood would be present in the ventricle, so that is gonna open up the obstruction. Whereas the aortic stenosis, it has nothing to do with greater and systolic blood volume in the chamber. The only thing it has to do when it comes to hand grip is the fact that blood is not able to flow that quickly across the valve anymore because of greater systemic vascular. As soon as the blood leaves the valve, there is greater back pressure, the blood flows really slowly across the valves. That is why when it comes to hand grip, that is increase in afterload only, the AS murmur also gets softer. So let's give it a read as well. Tip, I already told you about the main tip. The only two things you need to remember are what all these maneuvers do to the preload and afterload, the exception murmurs that get softer with greater amount of blood in the chamber, and what happens to the murmurs when it comes to hand grips, specifically the murmurs of HCM and aortic stenosis. These three things are the ones that you need to keep in mind. Other than that, everything is gonna make sense really easily. So the questions here: which murmurs are hollow systolic? That is, they make the same noise throughout the cycle. Uh, a mitral regurgitation, mitral insufficiency murmur plus tricuspid regurgitation. These are the murmurs that are systolic throughout. Why? Because when the ventricles contract, the blood regurgitates throughout the systolic cycle. That's why. As well as ventricular septal defects. If you just have it, when it comes to solving questions, if you have all these things on your fingertips, it becomes really easy. Someone asks you which are the hollow systolic murmurs, you say the murmurs of the tricuspid regurg, mitral regurg, and VSD. They are hollow systolic. End of the story. Which murmurs are mid systolic? That is, they start at the mid of the systole. That is aortic stenosis. It's a crescendo decrescendo systolic murmur. What do you mean by crescendo decrescendo? Crescendo decrescendo means when it comes to the sound of the sound of the murmur slowly goes up like this and then comes down like this. Why does this happen? This happens because as this is the stenosed murmur and this is the ventricle. So during the start of the contraction, less blood is flowing through the stenosed valve. So the sound is like this. As the ventricle contracts more and more blood starts flowing. So the sound goes from less, more to it peaks. And then when the contraction stops and the back pressure hits the valve, so the blood flow across the valve then reversibly, paradoxically starts reducing, since the ventricular force has now been diminished and the back pressure is coming into action. So the flow across the valve now starts decreasing again. So slowly the voice of the murmur also decreases. So that's why as the contraction of the ventricle proceeds, the sound gets louder, and when the contraction is complete, the backflow kicks in, the flow across the valve gets slower, and the voice goes down like this. So this is termed as crescendo, which means increasing, decrescendo, which means decreasing. So this is how you make sound. And in which phase does this happen? It happens during systole. And when does it start? Mid systole, because during the initial systole the valve is stenosed, the blood does not flow across it. So if they ask you a mid systolic murmur that is crescendo decrescendo in nature, that is going to be aortic stenosis, hypertrophic obstructive cardiomyopathy, which is also a form of outflow tract obstruction, and pulmonic stenosis. They go hand in hand. Aortic stenosis, pulmonic stenosis, same mechanics. Which murmur has a diastolic opening snap? Diastolic opening snap means during diastole, that is during contraction of the atria, there's going to be opening snap. Mitral stenosis murmur is a diastolic murmur with an opening snap, followed by a mid or late decrescendo diastolic murmur. What do you mean by decrescendo? It's gonna be decrescendo means the sound of the murmur is gonna be maximum at the start and then it's gonna decrease. This part is called decrescendo and the upgoing part is called crescendo. So if they mention decrescendo only, it means it's louder at the start and then slowly gets softer. If they mention crescendo, it's softer at the start, gets louder at the end. If they mention both, so it means it's softer, it gets louder, then it gets softer again. Crescendo decrescendo, that's how you make sense of it. Crescendo decrescendo. Why is the murmur of mitral stenosis decrescendo in nature? Because initially, when the atria contract, there is no blood flow across the stenosed mitral valve. But as soon as the mitral valve opens after an opening snap, there's a maximum amount of sound, and then as the atria just completely lose the blood and fill it in the ventricles, it goes down like decrescendo. So which murmur is gonna be decrescendo in nature and diastolic with an opening snap? That is mitral stenosis. Which murmur has a mid systolic click? That is mitral valve prolapse. You need to keep all these steps in mind. Which murmur is described as late peaking systolic murmur with an ejection click? That is aortic stenosis. Why late peaking? Because it's gonna be crescendo, it's going up, since maximum amount of ventricular contraction is required to cause the maximum amount of blood to flow across the stenosed valve. So it is late peaking. Initially, when the ventricular contraction is really less, it's not gonna go really up. But when the contraction peaks, it peaks, but not at the start of the systole, at the mid of the systole. Ejection clip, that is basically another term for saying opening snap. Ejection click, opening snaps, a short systolic murmur at the cardiac apex. If the mentioned cardiac apex, it's mitral involvement that disappears with squatting. What happens during squatting? We're going to discuss it as we go. What happens during squatting? Increase preload, so greater amount of blood in the chambers. Which murmurs get softer with greater amount of blood in chambers? That is HOCM and mitral valve prolapse. They have mentioned cardiac apex, so this murmur would be mitral valve prolapse. That's how you decipher what murmur is most consistent with mitral valve prolapse. Cardiac auscultation in patients with MVP typical shows no ejection clicks and or mid to late systolic murmurs of mitral regurg. It's simple as that. I just made it. Apex mitral involvement decreases, gets softer with squatting. Either MVP or HOCM. HOCM occurs at A and P regurg area. So it's not A and P, it's the apex. So it's the mitral area. So mitral valve prolapse. Squatting from standing position increases venous return, in which in turn increases left ventricular size and volume. This leads to delay in valve prolapse, a later click and shorter murmur. However, in patients with severe mitral regurg from MVP, the murmur may increase in intensity with squatting due to increase in afterload. They are talking about mitral regurg here. They're not talking about mitral valve prolapse. And severe mitral valve regurg can be a reason or a sequel or sequely to mitral valve prolapse. So patient might have mitral valve prolapse, and when it gets worse, it leads to mitral regurg. Echocardiogram is used to make a diagnosis. Obviously, echo visualizes the heart or the chambers, left ventricular ejection fraction, left ventricular and diastolic volume, left ventricular and systolic volume. Everything related to the hemodynamics of a heart can be visualized when you do an echocardiogram, including the valves, how the blood is flowing across the valves, how the valves are opening, how the valves are closing. So any valvular pathology, including the one we study like infectious endocarditis, if you're suspecting it, you do an echo because it confirms the presence of vegetations. So summary of this paragraph would be systolic murmur at apex that disappears with squatting. Mitral valve prolapse, because it is at the apex, it is a systolic murmur. When the ventricles contract, the mitral valve is prolapsed into the atria, and that is why the sound occurs during systole. So systolic murmur at apex, that is the mitral area, disappears with squatting, MVP. Systolic murmur at left sternal border, that disappears with squatting, HOCM. So this is the difference that I wanted to highlight for you guys. Several non-specific symptoms. So this is also really cool. Atypical chest pain, dyspnea, palpitations, dizziness, anxiety, panic disorder, non-specific echocardiographic changes have been attributed to MVP. These signs and symptoms in patients with mitral valve prolapse are called mitral valve syndrome, MVP syndrome. So the MVP syndrome, it's not that important here, but yeah, you need to keep that in mind as well. So benign versus pathological murmurs. So usually whenever a question comes up, they give you murmurs and you get really confused, like how do I decipher if it's a murmur that is benign and pathologic? So, whenever you hear a murmur, don't go about freaking out that there's a problem. There are benign murmurs as well, and I'm going to highlight the three most important ones and their characteristics. So, maneuvers that decrease venous blood return to the heart typically reduce the intensity of innocent murmurs. What are innocent murmurs? Innocent murmurs are the murmurs that are not pathological. They are asymptomatic. There would be normal growth in the child, no significant family history. They are just murmurs. So the three important ones are pulmonic flow murmur. That is the most important one in my perspective, but there is not a question that comes directly about pulmonic flow murmur. They usually give a question regarding venous hum, but pulmonic flow murmur, that is usually mentioned when it comes to question stems. So what happens and why does this pulmonic flow murmur happens? It just happens when there is a great amount of blood flowing across the pulmonic valve. Systolic ejection murmur best heard over the left, or it would be heard at the pulmonic area, may radiate to the axilla. In AST, fixed splitting of S2 and systolic murmur, the systolic murmur here is pulmonic flow murmur. S2 and in ASD, fixed splitting of S2 and a systolic murmur. So it's usually associated with ASD. And one more thing, wide splitting just means right ventricular hypertrophy. As I told you about, why would wide splitting of the S2 sound occur? It would occur when there is stenosis of the pulmonic valve. That is when the wide splitting occurs. And stenosis of the pulmonic valve or or right ventricular hypertrophy or right ventricular bundle branch block. In all these scenarios, there is a delayed closure of the pulmonic valve. For example, in right ventricular hypertrophy, because the right ventricle is really muscular, it's really pumping a lot of blood across the pulmonic valve. So the closure of the pulmonic valve is going to be delayed. That would result in wide splitting. So wide splitting basically just means right ventricular hypertrophy, right bundle branch block, or direct pulmonic stenosis. So basically pulmonic flow murmur is a murmur that happens when associated with ASD and happens when there's a lot of blood flow across the pulmonic valve. For example, if a patient is pregnant and there's a hyperdynamic circulation going on, you're gonna be able to hear a murmur at the pulmonic area. Don't get confused that there's a problem. In pregnant women, this murmur is highly likely and it is possible. So, how do you differentiate between the pathological and benign murmurs? So, whenever you see a murmur, just don't go about assuming that it's pathological. It can be a benign murmur as well. So, what are the things that are going to point towards a murmur being pathological? That is, it is associated with some abnormality, such as like poor weight gain, when it comes to infants, older children, chest pain, syncope, anything that is out of the ordinary, anything that is causing any sort of trouble, and you also see a murmur there, then that's a hint that that murmur might be pathological. Other than that, if you hear a murmur and the patient is completely fine, most probably it's a benign murmur. Another thing, benign murmurs are systolic in nature usually. So how do you sideline a benign murmur? First of all, there are going to be no pathological symptoms of any sort like respiratory distress, chest pain, or hypoxemia, anything like that. And in addition to that, that murmur would be systolic in nature. That is how you identify a benign murmur from a pathological one. So if you just memorize the three benign ones, you'll most probably able to make a difference between both of them. So these are benign murmurs are also termed as innocent murmurs. So one of the two important things in different ways, I've explained them written here. Innocent murmurs increase with increase in preload. For example, the preload increases when you lie down in a supine position, so more venous return. Decrease with decrease in preload. For example, if you do a Valsalva, there is a decrease blood going towards the heart. When you stand up suddenly from a seated position, the blood pools down, and then there is also a decrease in venous return, except for the venous hum murmur. Venous hum is also a benign murmur. Still's murmur is a benign. Pulmonic flow murmur is a benign murmur, and venous hum is a benign murmur. This is the murmur that is questioned a lot, and this is the murmur that comes in statements a lot. So all of these three are benign murmurs, and all of them, like the still murmur and the pulmonic flow murmur, increase when there is increase blood in the chambers. Like I've written here, increase with increased preload. And another way of saying the same thing is increase with greater blood in the chamber of the heart, the innocent murmurs, except for the venous hum. So the venous hum is one of those murmurs that decrease when there is an increase in blood volume in the chamber. So all of them are gonna be systolic in nature, and the locations. Pulmonic flow murmur, as the P pulmonic states that it's gonna be heard at the pulmonic area. As I also explained earlier, it happens when there's hyperdynamic circulation going on. Venous hum, it's continuous, best heard over supra or infraclavicular area, decrease intensity with neck rotation. That is one of the high yield points that you have here, which is in decrease intensity with neck rotation. And one more thing, venous hum, as I told you, when there is increase in blood in the chamber, the venous hum decreases. For example, which maneuvers, you ask, that which maneuvers are gonna decrease the venous hum? Like if you do a Valsalva, or if you stand up and there is a decrease in preload, then what is gonna happen? The murmur is gonna increase. So and when there's increase in preload, like you are in a supine position, then that is gonna decrease the venous hum, because it is the innocent murmur that is the anomaly here. So in summary, we have three innocent murmurs: the pulmonic flow murmur, the still murmur, and the venous hum. The first two ones, they increase with increase in blood in the chamber, and the third one, that is the venous hum, it decreases when there's an increase in blood. So you can make a difference between all the maneuvers depending on whether the murmur gets louder or smaller. These innocent murmurs would not be associated with any pathology like respiratory distress, hypoxemia, heart failure, anything like that. They are going to be systolic in nature, and their location: pulmonic flow murmur at the pulmonic area, Still's murmur left lower sternal border at the ANP regurg area. Still's murmur is gonna be at the ANP regurg area. Pulmonic flow murmur is gonna be at the pulmonic area. Venous hum would be continuous, and it would be best heard at above the clavicles. And decrease intensity with neck rotation, that is a high yield pointer for venous hum. So all of them are systolic. Venous hum is the anomaly that decreases with increase in preload. All of them are systolic, and pulmonic at the P area, stills at the ANP regurg area, and venous hum at the above the clavicles. So this is another form of question that is usually asked. So these are the four chambers of the heart. This is superior vena cava, this is pulmonary artery. So let's just dive into it without reading. We have to tell what's the anomaly here: ASD, VSD, what is going on here. So the blood comes, the deoxygenated blood comes at 73%, enters the right atrium and suddenly becomes 85%. That is not possible until unless there is mixing of the oxygenated blood, which is possible only when there is a shunt between the left atrium and the right atrium, and the highly oxygenated blood from the left atrium moves towards the right atrium. So this diagram here shows a ASD, or patent foramen ovale. So 85% goes into the right ventricle, stays the same, then it enters the pulmonary artery, stays the same, then gets oxygenated and becomes 99%. Why does it go from 99 to 96% here? Because some of them it is going back to the right atrium, then it stays the same. So for example, you can see above the question how somehow O2 increases from superior vena cava to the right atrium, which is ordinarily impossible. The only way this could occur is if an ASD is present. So ASDs can sometimes be responsible for paradoxical emboli. What is a paradoxical emboli? Usually when you have a DVT, it comes and enters the right atrium, right ventricle, then it lodges onto the pulmonary circulation, but it can sometimes lodge into systemic circulation, which is normally not possible. It is only possible if the emboli enters the right atrium, then somehow manages to get to the left atrium, and then it is lodged into the systemic circulation, where it causes trouble like cerebral infarcts, renal infarcts, or splenic infarcts. So that is only possible if there is a patent foramen ovale or a ASD, which in this case, this is termed as paradoxical emboli, emboli that paradoxically enters systemic circulation. VSD does not cause cyanosis at birth. The problem, one of the high yield things that you need to know is which problem causes cyanosis at birth and which presents with a delayed cyanosis after birth. VSD does not cause cyanosis at birth. It is asymptomatic. Only years later, after the higher flow to the lungs results in pulmonary hypertension followed by right ventricular hypertrophy and reversal, can the patient become cyanotic. So this is so high yield. I can't even stress it enough that the VSD is gonna be asymptomatic at birth, and after some time, what is initially going to happen? Follow my cursor here. So VSD would be present here. Initially the blood would flow from the left ventricle because it's more muscular to the right ventricle, and then it's going to go to the pulmonary artery. And what happens when this keeps going on? The blood in the pulmonary circulation develops a hyperdynamic or hypervoluminous circulation that eventually results in pulmonary hypertension. And when this process continues over years and years and years, what happens is that the right ventricular hypertrophies, because it has to pump blood against increased pulmonary vascular resistance due to the developed pulmonary hypertension. When the right ventricular hypertrophy becomes enough that it becomes even more muscular than the left ventricular, so then the right ventricular starts pumping blood and the shunt reverses. From now the blood starts flowing from the right ventricle to the left ventricle instead. And when this starts happening, the mixing of the deoxygenated blood to the oxygenated blood, this is when the patient becomes cyanotic. So you need to keep this in mind. VSD is asymptomatic at birth, and after the right ventricular hypertrophies to a significant extent because of the developed pulmonary hypertension, then and only then the mixing of the deoxygenated blood and the left oxygenated blood happens due to the shunt reversal. Initially the blood flows from left ventricular to the right. Now after the right ventricular hypertrophies, it reverses, and then is when the patient becomes cyanotic. So when it comes to VSD, two more important things and the questions that you need to keep in mind are: when the patient is a newborn, initially the murmur of the VSD is really soft. And what is the reason behind the murmur of the VSD being really soft? I'll draw it here for you guys to make it easy. So if this is the heart and these are the four chambers, you can assume that the top ones are the atria and the lower ones are the ventricles. So initially the blood is moving from, let's assume this is the pulmonary vein and this leads to the lungs. So initially what happens is that when the patient is born, the lungs are filled with fluid and the lungs are not openly properly expanded, so all the vessels inside the lungs are collapsed. That results in a greater pulmonary vascular resistance. So initially the pressure in the right atrium is really high. Why is the pressure in the right atrium is high? Because it is pumping blood against a greater pulmonary vascular resistance. Due to this greater high blood pressure, the blood flow across the VSD is really small, so the murmur can't be heard that well. But as the days progress and at about 5th, 6th, 7th day, when the baby starts breathing properly, the lungs have now expanded and the vessels are now opened up, because they are ready to facilitate the gaseous exchange and everything, and the lungs are ready and they are working and they're functional. So there's a marked reduction in pulmonary vascular resistance, which then results in a greater amount of blood flow in the pulmonary vein from the right ventricle. And now what happens is that the blood pressure in the right ventricle decreases because the blood is freely flowing towards the lungs, and the lungs are open, and now the blood flow across the VSD increases because there is less blood pressure in the right ventricle, and the blood flowing from the left ventricle to the right ventricle moves with ease. So the sound of the murmur now increases. So this is the reason behind, if they ask that the patient had a VST and it's not that audible during when the patient is born. What is the reason behind that? The reason is that there's greater pulmonary vascular resistance, and that results in greater pressure in the right ventricle. So the VST flow across the VST is not that well, and the murmur is softer. And if they ask at the seventh day the murmur is really loud, what is the reason behind that? So the reason behind the murmur being really loud at the seventh day is that reduction in the pulmonary vascular resistance due to the opening up of the lungs. That results in a louder murmur because the blood flow is now increased across the VST, because there's not much pressure in the right ventricular now. So let's give it a read as well. Murmur can be silent or soft at birth, followed by loud at 7 days of life. The USMLE will ask why the murmur is louder now. Decreased pulmonary vascular resistance, that is, the lungs open up during the first week of life, resulting in decreased right ventricular pressure and an increase in the left to right pressure gradient. More blood flowing from the left to right ventricular, greater sound of the murmur. Conversely, if they ask why the murmur was softer at birth compared to now, the answer is increased pulmonary vascular resistance that is present at birth, where the lungs were still closed at the time, so there was a lesser gradient of blood flow. Aortic stenosis, suspected aortic stenosis. What are you gonna do next? I told you about the imaging study that is also really high yield when it comes to the heart. You're going to do an echo, because that is going to confirm the stenosis, and it's going to visualize the stenosed aortic valve. And aortic stenosis can really lead to morbidity and mortality, and it's a really serious valvular condition. So it's taken really seriously when it comes to aortic stenosis. When you compare that to mitral regurg, yeah, it can be left a little bit. Mitral valve prolapse, you can go along with it, not that much of a problem. But when it comes to aortic stenosis, there are certain guidelines that you have to grade its severity, and you need to treat it. So if you suspect aortic stenosis, you will have to do an echocardiogram, because you need to confirm the severity of the aortic stenosis. Calcified, most common, usually the rheumatic heart disease patients initially have aortic regurg, then the valve calcifies over time, then they develop aortic stenosis. Congenital bicuspid valve, it's the same, the valve gets calcified and gets damaged over time because it's bicuspid in nature, and then the patients develop aortic stenosis. So the patients of the aortic stenosis would be older relatively. Common worldwide but rare in developed countries, the rheumatic heart disease. Initially it causes regurg, then it develops stenosis. So what is going to happen? Since there's the valve is stenosed, the left ventricle would have to pump more. It will lead to left ventricular hypertrophy because it is stenosed. The valvular closure would be delayed, so you're gonna get narrowed splitting and paradoxical splitting. Paradoxical splitting when you are inhaling, and paradoxical splitting when you are exhaling, and narrowed splitting when you are inhaling. That happens in aortic stenosis because there is a delayed closure of the valve. The valve already, the aortic valve closes more early than the pulmonic valve. So when there's stenosis, it gets closer to it. That happens when you are expiring, and when you are inspiring, the aortic valve is already closer. The pulmonic valve during inspiration, it also results in delayed closure. So the aortic valve now closes even later than the pulmonic valve. So the basic premise of the discussion here was that aortic stenosis lead to narrowed splitting and paradoxical splitting. I need to make a correction here when I said that aortic stenosis. What's going to happen in splitting is you're going to have narrowed splitting when it comes to inspiration, because during inspiration there is greater venous return and there is even more delayed closure of the pulmonic valve. So you're going to have, this is the closure of the aortic valve, and during inspiration the pulmonic valve would close, closure would be delayed. So this is what the narrowed splitting would look like in inspiration. And usually the aortic valve is gonna closure is gonna be here, but due in aortic stenosis, it's gonna get delayed. It's gonna come here. This is what happens during inspiration. Inspiration. So when it comes to expiration, the aortic valve closure is gonna be at the same location, but there is gonna be no more delay in the pulmonic valve closure. So the pulmonic valve would move from here. The closure would even be come from the delay or would be reduced, and the closure of the pulmonic valve would come to its original location, resulting in paradoxical splitting where the closure of the pulmonic valve would be heard first and the closure of the aortic valve would be heard later. So what I mentioned incorrectly was the timing when it comes to inspiration and expiration. So the paradoxical splitting would be heard during expiration and narrowed would be heard during inspiration. So I just wanted to mention that everything is interconnected if you keep revising. That's why I mentioned the splitting again, so that you can make a better sense of it. As I told you, stenosis results in delayed opening, delayed closure of the valve, and hypertrophy of the ventricles also results in delayed closure of the valve because greater blood is being squeezed. Left bundle branch, right bundle branch also results in delayed closure of the valve. So calcified, okay, dyspnea on exertion, decreased exercise tolerance. These are the biggest symptoms when it comes to aortic stenosis because the heart is not being able to pump enough blood towards the periphery. So there's dyspnea on exertion. Why does dyspnea occur? Dyspnea occurs when the body detects that the oxygenation of the tissue is not adequate. So there's a signal to the brain that not enough oxygen is being delivered, and that's why that leads to breathlessness. It's not a primary pathology of the lung, it's just the body sensing decreased oxygenation, decreased exercise tolerance due to the same reason. Angina pectoris, why this occurs? I'll explain the reason behind everything. This occurs because there's left ventricular hypertrophy and the left ventricular blood supply is not been able to keep up with increased workload, since the ventricle has to pump more against a calcified aortic valve. Syncope, this occurs if there's a marked reduction of blood flow towards the brain. So yeah, the person can also have attacks of syncope. Heart failure, that progressively develops when the ventricle finally gives up pumping blood across massive amounts of resistance. Aortic stenosis, as I explained to you, the sound would be like crescendo, decrescendo. Crescendo means going up in sound, no sound at the start, and the sound increases. And decrescendo means it's maximum at the start and then decreases. And crescendo, decrescendo means it's not that much at the start, then it increases and becomes maximum at the mid, and then it starts decreasing again. Why is this aortic stenosis sound crescendo, decrescendo? Because at the start of the ventricular contraction, the blood flow across the valve is not that much, so the sound is very less. As the ventricles peak in contraction, the sound gets greater and greater and greater, so it goes up. And as there is maximal contraction and after during relaxation, the blood flow across the valve decreases and the sound goes down in a decrescendo manner. So crescendo, decrescendo murmur, it's gonna be heard at the aortic area. Let's just revise that again. A P, A N P regurg, T M, AST, AST, VST. I'ma just do it again just for the sake of doing it. A P, A and P regurg, T M. P is gonna be AST, T is gonna be AST and VST. So that's, I just have an OCD of some sort. That's gonna make it easy for me. A, P, ANP regurg, T, M, AST, AST, VST. That's how you do it. So slow rising, why are they gonna rise slowly? Because the initial pump would not result in that much blood flow during the peak contraction. That is where you're gonna get strong carotid. So initially the pulse is gonna be weak and then it's gonna get stronger. So these 2 points, crescendo, decrescendo, and slow rising or weak carotid pulses, this is really high yield when it comes to aortic. The pulse is going to rise really slowly because as the ventricle contracts and generates maximum force, that is when you're going to have maximum blood flow in the vessels, aortic valve replacement for severe aortic stenosis. So the main premise of this discussion is gonna be how are you gonna grade whether you need aortic valve replacement or not. So, one of the confusing things is pre-syncope or syncope. Cerebral perfusion pressure decreases during exercise because cardiac output cannot increase efficiently to offset the decrease in systemic vascular resistance that occurs with exercise-induced peripheral vasodilation. Why does syncope occurs during exercise? The reason why the syncope occurs is because the blood vessels in the muscles are gonna dilate when you're exercising, and that sudden decrease in systemic vascular resistance is gonna shunt the blood towards the muscles more, and then if you in that case you get cerebral hyperperfusion, you're gonna get lightheadedness. That is the mechanism behind pre-syncope. So as I told you, transthoracic echo is gonna be done in all patients who are suspected to have AS to confirm the diagnosis, assess the severity of AS. That's also another reason. Definitive treatment is surgical valve replacement. Now, what are the physical examination findings of severe aortic stenosis? I slow rising, slow peaking carotid pulses, crescendo, decrescendo, murmur, and you're gonna get during its whoa, I told you about it's gonna result in delayed closure of the valve, so you're gonna get paradoxical split in expiration and a single S2. A single S2 during inspiration is also pathological. Usually, physiologically, there should be a split in S2. If there's a single S2, this is pathological. That means that the aortic valve has been delayed to the point that it is almost close to the pulmonic valve sound. So there's a single S2, and during expiration, because the A2 is delayed, so then you can hear the P2 first and A2 later. The severely stenotic valve leaflets cause a soft aortic valve closure and delay, so they're explaining the same thing that I just mentioned. Other conditions in other conditions in which paradoxical splitting would be appreciated, anything that results in delayed closure of the aortic valve, such as left ventricular hypertrophy, left bundle branch block, HOCM. How left greater squeezing of the blood through the valve, the valve is gonna close later. Delayed left bundle branch block, the contraction is gonna start late, so it's gonna end late. Delayed closure. HOCM, hypertrophied left ventricular, so greater squeezing of the blood. Patient presents with features of AS. You suspect AS based on the murmur. Location of the murmur is at the aortic area, slow rising pulses, and patient also has symptoms. What do you do next? You do an echo. That's why I mentioned this question. Pulse pressure in aortic stenosis would be decreased. Pulse pressure is the difference between the systolic and the diastolic blood pressure. So that is reduced in AS, but when it comes to aortic regurg, it's increased, because when the blood flows, this is, let me draw it for you. This is the aorta, this is the valve. So if you have regurg, the blood flows at a rapid rate, but since the valve is incompetent and the valve cannot prevent the backflow of the blood pressure back into the left ventricle, the valve closes like this, and a lot of blood starts leaking back. So the systolic blood pressure, if it comes at around 120, due to the blood flowing back into the left ventricle, the diastolic blood pressure comes out to be about like 60. So there's a huge difference between 120 and 60, that is of 60. This is gonna be the pulse pressure in case of aortic regurg. So the pulse pressure is greater when it comes to aortic regurg, but when it comes to aortic stenosis, this is termed as the widening of the pulse pressure. You're gonna appreciate that in aortic regurg, but when it comes to aortic stenosis, what happens is, since the blood only reaches the maximum velocity when there's peak contraction of the ventricles, and the valve is stenosed, when the blood pressure reaches its peak flow and it achieves a systolic blood pressure of 120 and the contraction stops, what happens is that all the blood just piles here. There is no question of regurgitation. Instead, what happens is that due to the stenosed valve, the systolic blood that usually would be achieved about 120 would reduce to at about 100. So the mechanism behind the pulse pressure decreasing when it comes to aortic stenosis is that you are not able to achieve the maximum systolic blood pressure of 120. It would instead be 100 because the stenosed valve would not allow that much blood to flow and create that much pressure, and the diastolic would just be normal, but as you see the difference turns out to be just 20. So this is narrowing of the pulse pressure when it comes to aortic stenosis. I just explained the mechanism behind why you would get a widening in pulse pressure when it comes to AR and narrowing when it comes to AS. The reason for narrowing is you cannot achieve a maximal systolic blood pressure, and the reason behind increasing here is there's an excessive drop in diastolic blood pressure. So you see that's a funny difference between both of them. In the stenosis you cannot achieve the maximum systolic, so there's narrowing. In aortic regurg you cannot, there's a exaggeration of decrease of the diastolic blood pressure due to the regurg, so you get an increase in the pulse pressure. Important manifestations of aortic stenosis: syncope, inadequate cerebral perfusion during exercise, as well as during exercise there's vasodilation in the muscles, that's the angina due to left ventricular hypertrophy leading to supply demand mismatch, and early peaking systolic murmurs suggest mild to moderate. In patients with mild to moderate AS, anginal symptoms are likely due to another cause, most commonly obstructive CID. So if a patient has aortic stenosis, you might confuse the anginal symptoms to be a result of just aortic stenosis, but if it's mild or moderate, you need to suspect coronary artery disease as well, because especially if the patient has comorbids such as diabetes and hypertension as well. So in a patient, what I mean to say is, if a patient has aortic stenosis and has angina, it's not written in stone that the reason is just AS. It can be coronary artery disease as well. So we now come to the most important part of the discussion. That is, what is the criteria for severe aortic stenosis? You need to memorize this. There's no way around it. The transvalvular pressure gradient being 40 or greater than 40, or uh, valve area less or equal to 1 centimeter square. You need to memorize this. There is no other way. Indications for valve replacement, yeah, you can decipher them, that's sure, and I'm gonna explain you how you can do that. But when it comes to the criteria for severe AS, you need to memorize that the transvalvular gradient would be greater than 40, and one way to memorize is that you get a 4.0 and then you remove the 0, you get 40. So aortic jet velocity 4, in all of these three you'll get equal to or greater than, or equal to or less than. So equal to is common in all of them. You get 4.0, you get 4.0, you get 1.0. So aortic jet velocity either 4 or greater than 4, transvalvular pressure 40 or greater than 40, and valve area, it's not that important, but these two are the most important ones. So if you get any one of them, it's not required that you get all three, just any one of them, plus the patient is having troubles because of aortic stenosis, you're gonna go for a valve replacement. What troubles? You ask yourself, what troubles can the patient have? The patient might have lightheadedness, syncope during exercise. The patient may have anginal symptoms because of strain on the heart. The patient can have yeah, these two important ones are the anginal symptoms due to heart strain and cerebral hyperperfusion leading to syncope, and left ventricular ejection fraction less than 40, less than 50. Now you ask, this is the normal left ventricular ejection fraction. Why is this an indication for valve replacement? Because when it comes to aortic stenosis, you need even a greater amount of left ventricular ejection fraction in order to meet the needs of the body, because the valve is stenosed and a lot of ejection fraction is required to make sure that a lot of blood or the adequate amount of blood is being pumped towards the body. So If an ejection fraction is less than 50, that means that the left ventricle is not being able to keep up with the needs of the body, because when it comes to a normal heart, an ejection fraction of 50 would be enough to pump the blood across the valve. But when it comes to aortic stenosis, the valve is already stenosed, dude. You need a lot of ejection fraction to compensate for that stenosis. So if it's less than 50, that is also an indication. So now if you form a combination, it's really easy. Patient has a transvalvular pressure gradient of 40 or greater than 40, and the patient is complaining of he just fainted 2 times in the past month. You go for a replacement. Or the patient says he has pain in the chest sometimes. You go for a replacement. And if you do an echo and you see that the ejection fraction is 45, you go for a replacement. The ejection fraction is 40, you go for a replacement. The ejection fraction is 50, uh, you don't go for a replacement, and no symptoms. The aortic jet velocity is greater or equal to 4, and the patient has an ejection fraction of 45. You don't go for a replacement, because you need one of them or one plus one of these. Aortic valve replacement is the only therapy proven to work. Surgical aortic valve replacement should be considered in patients with severe aortic stenosis, which would be graded by one of these factors and one of the following criteria. Presence of symptoms attributable to severe. One of these symptoms, severe is left ventricular ejection fraction less than 50. These are the symptoms that represent all of these. Left ventricular ejection fraction less than 50, any symptoms due to AS, and undergoing cardiac surgery. And if the person is undergoing cardiac surgery, you're already opening the person, yeah, you can go for a replacement if severe AS criteria is met. So basically you just need to memorize all three of them. And if AS is causing trouble, and if you see that the ejection fraction is in the normal range or less than 50, you need a lot of ejection fraction to compensate for AS. So if it's less than 50, you replace the valve. Serial echocardiography. So they most probably gave a patient in a question who had a left ventricular ejection fraction less than 50 and met the severe AS criteria, and they said, can we do a serial echocardiography just to monitor the patient? No, you need to replace the valve. Serial echocardiography is appropriate in patients with severe AS who are truly asymptomatic. That is, they're not having symptoms, or the ejection fraction is greater than 50 and have a normal left ventricular ejection fraction, but not in this patient with a left ventricular ejection fraction of less than 50. So the normal ejection fraction, according to some data suggests, that it's 50 to 70. So if it's less than 50, that's a no, absolutely no go, because even a slight reduction in the ejection fraction cannot compensate when it comes to aortic stenosis. That means the heart is going towards failure and you need to replace the valve ASAP. Severe AS is a progressive disease that requires either prompt replacement or close monitoring. Reassurance should not be selected as an answer. Severe AS creates a tenacious hemodynamic situation because adequate preload is required to maintain cardiac output and adequate diastolic pressure is required. So you cannot use diuretics, because when you use diuretics, they're going to reduce the preload. Already there's a lot of resistance when it comes to the blood, when it comes to the heart meeting the requirements of the body. And if you reduce the preload using diuretics, that's going to exacerbate the situation. And if you use vasodilators, they are going to reduce the diastolic pressure, amlodipine, hydrolysine, or ACE inhibitors, and that can lead to clinical decompensation. If already the heart is barely keeping up and you reduce the diastolic blood pressure or you reduce the preload, it's going to decompensate. So you don't use these when it comes to AS. So these are the important things that you need to remember. And the one that I mentioned, that you need a ejection fraction of more than 50. Usually when there's a patient without aortic stenosis, ejection fraction of a 50, of a 45, 40 after a heart attack, usually it drops to 45, 40, sometimes even 30, 35. The patient can survive. But when it comes to aortic stenosis, the patient might not be able to survive because there's a lot of resistance. So yeah, we're really touchy when it comes to the ejection fraction. So this is an other comparison of aortic stenosis and hypertrophic obstructive cardiomyopathy. So both of these murmurs are gonna decrease when there is greater blood in the left ventricular